Neither BNP nor NT-proBNP is universally better for a baseline diagnosis, as both carry Class 1 guideline recommendations for diagnosing heart failure and establishing prognosis. However, in contemporary clinical practice, NT-proBNP is generally preferred primarily due to its compatibility with current guideline-directed medical therapies and its distinct pharmacokinetic advantages. Here is the clinical breakdown of why the shift towards NT-proBNP has occurred, along with the caveats where BNP still holds value. The ANI factor. This is the most significant clinical differentiator today. BNP is a direct substrate for neprilysin. When a patient is on ANI, that is angiotensin receptor neprilysin inhibitor, neprilysin inhibition blocks the degradation of BNP. This causes measured BNP levels to rise or fail to decrease independently of the patient's actual hemodynamic status. NT-proBNP is an inactive fragment that is not degraded by neprilysin. It is cleared passively. Therefore, NT-proBNP accurately reflects the true reduction in ventricular wall stress and improved hemodynamics when a patient responds to ARNI therapy. Current guidelines specifically recommend NT-proBNP over BNP for monitoring patients on an ARNI. Half-life and diagnostic sensitivity. When the cardiomyocyte is stretched, it secretes proBNP, which is cleaved by corin into equimolar amounts of BNP and NT-proBNP. BNP is the biologically active hormone with a short half-life of roughly 20 minutes. NT-proBNP is biologically inactive and has a half-life of roughly 120 minutes. Because of this slower clearance, NT-proBNP circulates in much higher concentrations, roughly a 6:1 ratio in heart failure with reduced ejection fraction, though this varies by atrial fibrillation status and renal function. This higher circulating concentration makes NT-proBNP a more sensitive marker for detecting earlier, milder forms of heart failure, where BNP might still hover near normal limits. In vitro stability. From a laboratory and logistical standpoint, NT-proBNP is significantly more robust. BNP degrades rapidly at room temperature via contact activation of the coagulation system, requiring plastic tubes and rapid processing or chilling within 4 to 6 hours. NT-proBNP remains stable for several days at room temperature, making it far more practical for outpatient clinics where samples must be transported to a central lab. Where BNP still holds value, the caveats. While NT-proBNP is a standard for long-term monitoring, its strict reliance on renal clearance requires clinical nuance. Because NT-proBNP is strictly renally cleared, its levels are disproportionately elevated in patients with severe CKD compared to BNP, which enjoys dual clearance via neprilysin neutral endopeptidases and NPRC receptors. This is why NT-proBNP requires strict age-adjusted cutoffs to avoid false positive. Acute hemodynamic shifts. In a critical care or ICU setting, BNP's rapid 20-minute half-life allows it to reflect acute hour-to-hour hemodynamic changes faster than NT-proBNP, though practically this rarely dictates the choice of assay over NT-proBNP. Ultimately, while both are excellent diagnostic tools, the evolution of guideline-directed medical therapy makes NT-proBNP the more reliable, future-proof biomarker for the longitudinal lifetime management of heart failure patients.